Welcome to EMS Office Hours. This is Jim Hoffman. These are your Monday Minutes. Today, guys, we're going to continue on with the EMS Quick Study Guide help tips and stuff that you can get familiar with when you're taking exams. And we're going to go on into trauma still. We just finished up with the bleeding and shock, and now we're going to get into some more specific things like chest trauma or thoracic trauma. Okay, and this is part one of the chest trauma series. We talk about how things that can affect the patient's ventilation. All right, now of course I always try to mention why this stuff is important, guys. It's not just for your exams, right? It can help you with the exam, give you the key information, but it's also designed to build your knowledge base, to help you make better clinical decisions, write better reports, interact more effectively with your patients, okay, and with your healthcare professional partners, doctors, nurses, things like that. So before we get into it, of course, just kind of the basic kind of overview, right? We talk about chest injuries, that about 20% of all traumatic deaths are because of chest injuries, all right? And it's actually the second leading cause of traumatic death when we talk about people who have traumatic injuries. So rapid transport is their best chance, right? Less than 10 minutes out in the field. Now, let's talk about just this focus today on the injuries that interfere with ventilation. All right, and we talk about things like the clavicle, which is mostly kind of the common one you'll see a lot of because of the fractured bones there, but usually not significant injury enough where the patient will die. Then we talk about things like rib fracture, which is most commonly ribs 3 through 8, and more likely in adults. And it can be significant if the underlying organs, of course, are damaged by the force or the broken bone ends, right? The broken rib ends. Sternal fractures, again, you'll see this, but it's not that common. But when it does happen, the mortality rate is much higher. You're talking 25 to 45% because of the unstable chest wall, myocardial injury, and cardiac tamponade, right? Now, flail chest. This is something you'll see a lot in exams, guys. This is the 2 or more ribs broken, usually in 3 or more places, leads to that paradoxical motion, hypoxia. All right, this is a true emergency. You need to keep an eye on patients that have this, that they don't, deteriorate right in front of you, right? So, and again, this is the type of thing you'll see on exams. All right, talking about flail chest, they'll ask you, what does it mean? They'll mention things, hallmark signs like paradoxical motion, stuff like that. All right, so you keep an eye out for that when you're answering questions, because when they say things like a patient who's got 2 or more ribs broken in 3 more places, that would be an indicator of A, B, C, D, and one of them will probably be flail chest, right? So some things to think about there. Now, your pulmonary contusion, this is that bleeding that's in the interstitial alveoli areas of the lung. About 50% of patients with blunt trauma will have this, and you're going to have a real profound hypoxemia with this. It can develop. So think about patients that have that blunt chest trauma having that. Okay, now also we talk about getting that blunt trauma and broken ribs and things like that. Then we start thinking about other things, right? The pneumothoraxes, that little family of injuries, right? So you have your closed pneumothorax, and that's the air that enters the pleural space. The negative pressure that's there won't allow the lungs to inflate. That leads to lung collapse, and that's one part of it. Now the other is the open pneumothorax. Usually you think of that as being that sucking chest wound. So you get the penetrating trauma that creates that opening into the intrathoracic cavity, and you're going to have air that's going in and out of the pleural cavity, going in and out very freely of the pleural cavity, and then you get very severe ventilatory dysfunction, hypoxemia, and then death if you don't deal with it. And this is what we talk about using the occlusive dressing. Okay, Of course, depending upon your guidelines, where you are, how you go ahead and do that. Sometimes it's just, using foil and tape. Sometimes there's more commercial devices out there, but often they want you to go ahead and create that flutter valve. And the reason why that is because you don't want to go ahead and then wind up developing a tension pneumothorax, okay? And that's where the air is going into the pleural space, but now it can't get out, right? Because you put that occlusive dressing on, so it's not entering, out freely like it was with the open pneumothorax. So the pressure is going to build up, and then now you get to the collapsed lung, and then the heart gets compressed, the trachea can deviate. That's of course a much later sign, but you get that trachea deviation from the collapsed lung and from the heart becoming compressed. And most often than not, this is where you're going to be doing your needle decompression. Many guidelines will tell you that you can have all these symptoms and signs of a tension pneumothorax, but one of the things that qualifies the patient for a needle decompression is when they have a low blood pressure, okay, because of the pressure on the heart, and that's when the indicator is you have to do this life-saving technique of needle decompression. But of course, you're going to follow your local guidelines and what your medical control wants you to do or does not want you to do for patients that might have a tension pneumothorax. Now, want to round this out, guys, and talk about just some of the other injuries you might see. Airway injuries like injury to the esophagus, the trachea, the bronchi. Penetrating trauma can rupture these airway structures. Okay, it's not always that common of the esophagus or trachea being ruptured, but when it does, again, you have the higher incidence of mortality rate, about 30% when that does happen. So be aware of this type of stuff. Okay, again, guys, this is basic information. These are key elements that I want you to think about when you encounter these patients. And if this stuff is not ringing true or you're not really following me or understanding, I don't want to go into a whole lecture on this, right? This could be a 2-day lecture talking about chest trauma, but I would like it if you don't understand or it's not clicking with you. Open up your textbook, use a resource like my TurboMedic, and go ahead and delve deeper to further understand these key points. That's going to help you with your exams, and it's going to help you when you're treating and deciding how to transport and treat your patient effectively. Okay, now, just real quick, continuing on here to talk about diaphragmatic rupture. You gotta be careful with this, guys. This is your abdominal contents can actually rupture through the thin diaphragm wall and then end up entering the chest cavity, getting compressed lungs, the compressed heart, and then of course going into shock. All right, and that's when we talk about things like traumatic asphyxia, right? You get that severe crushing injury to the chest or the abdomen. The blood then gets forced up to the thorax, to the neck, to the face, and that can lead to death as well, coma, even seizures, things like that. So all these things can be happening. So this is why we early on in this little presentation, what did I mention about rapid on scene time, rapid transport to the hospital, because a lot of times these patients are going to require surgery, and there's not much you can do in the field besides giving fluid, maybe needle decompression, occlusive dressings, things like that, but you still have to fix that underlying cause of what's happening, right? So all this stuff is good to keep in mind, guys. Of course, always follow your local guidelines when it comes to this type of stuff and what you can do for patients and where you have to transport them to. All right, be aware of how it works in your area. But when it comes to exams and things like that, these are really, truly are the key elements you want to keep an eye out for. Okay, guys, again, I hope this stuff really does help you when you're preparing for your exam, you're thinking about what you're doing with your patients. If you do like this type of stuff, go check out my TurboMedic. You can actually get a free membership. I call it an insider membership because to me it's not free, because you are investing your time, effort, and energy into becoming a better professional in EMS, but TurboMedic does offer you gigabytes of digital content you can view right on your computer or download it. You have hours of audio and video. There are practice exams and even exclusive access to a private Facebook group and monthly live videos that I do there as well. And again, this is a free level membership. There is a premium level there as well. We get even more content available to you, but you can go ahead and join me as an insider here. Again, it's no cost. and you can go and get access to a lot of great content to start building your knowledge base a little bit more and doing better on your exams and in the field. So go check that out. It's at emsseo.com/insider. All right, guys, I'm going to end it there. Again, questions, comments, want to see a Monday Minutes of your own or something you're passionate about, show up here. Send me an email. It's contact@emsofficehours.com. And be sure to go check out emsofficehours.com for all the other episodes and the weekly podcast there as well. All right, that's it, guys. As always, have a great week. I am Jim Hoffman for EMS Office Hours in the Monday Minutes. Stay safe.